Hello, I'm Dr. Jay Noreen, and this is Health Talk. Today we welcome Bill DeVault, orthopedic surgeon at Appalachian Regional Orthopedics and Sports Medicine Center. AppOrtho is a member of Appalachian Regional Healthcare System, and it's the official sports medicine provider for App State Athletics. Dr. DeVault serves as medical director as well for the Rehab Center of Appalachian Regional Health System, both in Boone and in Linville. Bill, thank you very much for being here. We really appreciate it.
Pleasure to be here.
All right. Well, you know, I know there are a lot of people out there who would be interested to know how was it that you got into medicine in the first place and then moved to orthopedics and then on to sports medicine? And I know there's students out there who are particularly interested. Some of them are thinking about a career in medicine or healthcare.
Yes, my father was a high school football and basketball coach, so that was the sports medicine component that I later on adopted because I was used to being around the athletes. Even as a little kid, I would go to the games on the team bus when we did that. Then later on, when I was trying to decide what to do, I liked to do things that got results pretty fast. And eventually, I realized that, the medicine would do that, especially surgery, because you take a problem, you fix it, and then go on to the next problem. So along with mechanical aptitude, I always like to take things apart, reassemble them, rebuild a car engine, for instance, things like that. Eventually, that all led to medicine and being an orthopedic surgeon, and then to sports medicine.
Now, how did you make the transition to sports medicine from being an orthopod?
A lot of orthopedists traditionally do sports medicine, and so that was part of our regular orthopedic curriculum. And in med school, I went to Wake Forest to med school, and I would have experiences when I did my orthopedic rotation with sports medicine in addition to surgery and trauma and other orthopedic things like that.
But you actually went on and did a sports medicine subspecialty beyond your orthopedics, right?
Yes, I did. The training program includes medical school. I went to Wake Forest, as I'd mentioned, and then the University of South Carolina for orthopedic training, which is 5 years. And then I did a sports medicine fellowship, which is an extra year's worth of training in sports medicine at the Jewett Clinic in Orlando, Florida.
And I noticed that as you were sending some of your information that you actually worked with the Orlando Magic a little bit, the NBA team.
That's right.
Yeah, that must have been quite an experience.
That was a very interesting experience. I was there the year before Shaquille O'Neal got there. Yeah, so I just missed that, but we got to take care of the Orlando Magic and also in Orlando, University of Central Florida, Rollins College, and people from Disney and SeaWorld too, where they have a lot of performers, dancers, swimmers, skiers, that kind of thing.
Yeah. Well, we'll take some time, I hope, later on to talk a little bit about now your connection to App State Athletics as well. Could you also put it in a bigger context? You went to med school at Wake Forest, but how does your work here interrelate around the state? I expect you've got colleagues all around involved in sports medicine and orthopedics in general that you relate to.
Yes, that's true. For certain specialty problems, for instance, certain spine injuries or orthopedic oncology or certain specialty hand problems, we are able to have a connection with people at Wake Forest in Winston-Salem and also in Charlotte, for instance, so that if we needed a second opinion or a specialty problem that we don't do as much here, we can refer people out to those colleagues or call them and ask them for advice.
Sure. So it's a very collaborative kind of a situation.
It is.
Now, you also serve as the medical director of the Rehab Center. How does that work? As an orthopod, how do you relate to the Rehab Center?
Yes, physical therapy, when it's hospital-based or hospital-owned, requires a medical director. And also for orthopedics, physical therapy is such a large component of treatment of injuries or in post-surgical treatment that we collaborate with our physical therapists, our occupational therapists, go over patient problems, even go over to the therapy place while somebody's having therapy to watch what they do and to make suggestions and go over things that we can do to improve their therapy experience.
So that's a very close connection then.
It is.
Yeah. Could we talk a little bit about the sports medicine side of this? I know you do work with App State Athletics, but I also noted that you're working with High Country Soccer Association and I think some of the schools around the region. Can you talk a little bit about how you relate to athletic departments, App State and otherwise, as an orthopedic surgeon?
Yes, we actually use a team approach. We have an orthopedic team, Evan Ekman, another orthopedic surgeon with sports medicine specialty training, myself, physician's assistant. We have athletic trainers that we work with, and we attend many of the games, plus practices for contact sports like football and some basketball practices. And we also go to the training rooms that they have in different places around the campus, like at the main gym in the Convocation Center or the football field in the stadium, and see athletes who've been injured or have a medical problem after our regular work day.
What are some of the common problems you deal with athletes? I suppose it varies by sport, but what are some of the problems that you deal with typically?
Yeah, the typical problems, say with football, there's a lot of contact injuries, sprains, strains, sometimes even fractures, even though that doesn't happen very often. Ligament injuries to the shoulders and the knees. And with soccer, soccer's similar. A lot of knee and ankle injuries in soccer. Then with track and field, a lot of times it's related to overuse injuries because they train so intensely. So they might have strains and sprains, even stress fractures they get from the intense training, especially at the college level.
We have talked with Jody Cash, the Wellness Center director, about the approaches to preventing those kinds of strains and things. What are the kinds of advice you give athletes about, you know, what can you do to decrease the chance you're going to get a sprain or a strain of some kind?
A lot of it is being well conditioned first, so that they have less of a chance of overdoing it, particularly say in track and field at the beginning of the season or when they're focusing on the end of the season competitions. And also to be able to control activity. Sometimes it means reducing activity long enough for them to heal up from their injury and then increase activity again under the guidance of the physicians and the athletic trainers. Sometimes the athletic trainers will be seeing a person daily in the training room for treatments to try to get them returned to activity.
I'm going to have to take a break and clear my throat here. Excuse me. You did mention that you do spend time at practices and at games.
Yes.
Tell us how that works when you're on the sidelines. What are you actually doing?
Well, I would liken it to being a young parent where you have hyper attention to watching your kid go around, particularly in a crowd. So we watch the game to look for injuries, to look for safety issues. And so in football, for instance, we're roaming the sidelines back and forth to keep an eye on that. And then if somebody gets injured, the athletic trainers typically would go on the field, bring them off the field, we examine them. Occasionally we go on the field ourselves. And in the training room at the stadium, we have a small x-ray that we can look at people there. And of course they have EMS people around in case something more serious happens. We can take them to the hospital. That rarely happens, but we're certainly equipped for that too.
Bill, I know that your practice emphasizes substantially shoulder and knee problems. Can you talk a little about some of the common things you deal with, knee and shoulder?
In this location, since it's such a recreational area, we see lots of shoulder injuries all the way from things that happen with snowboarding and skiers to rock climbers, mountain bikers, and then on some of our seasonal people that come up from Florida or places like that, injuries to the shoulder from golfing, problems like that.
Well, I can relate to the shoulder thing. I did the dumb thing of planting my pole while skiing and rotator cuff tear. It wasn't any fun, I can tell you that much.
Oh yeah, I bet. And I've dislocated my shoulder before skiing for the last run of the day, and when it happened, it popped back in, but I knew what had happened. I thought, oh, that's going to hurt in a little while.
Yeah, I guess. Can you talk a little about the non-surgical approaches and when you have to go to the surgical approach for a rotator cuff or another kind of dislocation, other kind of shoulder injury?
Yes, for a shoulder dislocation, if it's a first-time injury, then a lot of times we will be able to treat them non-operatively with a period of immobilization or reduction of activity for about 2 weeks, and then physical therapy to start re-strengthening the joint and the muscles around the joint. Also, for rotator cuff injuries, especially if it's a small one, medications, cortisone injections, and then re-strengthening and rehab can be very effective. If that doesn't work very well, then we end up maybe having to do surgery.
But this is another example of where the connection of your role as an orthopedic surgeon and your role as director of the rehab center is a fit that's really important.
Yes, it is. I think that my estimation is that about, for shoulder surgery for instance, about 25% of it is the shoulder surgery and about 75% of it is the rehab to be able to get the function restored.
What proportion of I know it depends on how serious, but of these kind of shoulder injuries can actually successfully be treated without surgery, just kind of as a general rule? I
would think it is probably 60% may be able to be treated without surgery.
Oh.
Yeah,
that's a pretty impressive number, actually.
It is, and orthopedists act more like primary care musculoskeletal doctors, so we're taking care of a lot of sprains and strains and things like that, we allow healing time, therapy, re-strengthening, and that kind of thing.
Now, what about knees? What are some common knee problems you deal with, typically?
We have a lot of people with knee arthritis and ligament injuries like cruciate ligament or collateral ligament injuries and meniscus cartilage tears. The meniscus cartilages act like cushions between the bone, and when they get torn, they can hurt and grab and cause trouble that way.
Now, I know from friends and personal experience that there are options now to take care of those tears and those ligament problems by the arthroscope as opposed to open surgery. Can you talk a little bit about how that works for the person who's never had it? Of course, most people out there haven't had it. But.
Yeah, that's true. Yeah, the arthroscopic surgery has really been a boon for people. It's a small incision surgery, usually 2 or 3 very small incisions that are probably a ½ an inch. And we slide a fiber optic scope that's not quite as big around as a pencil and into the knee. This is done in surgery where their knee is numb or they're asleep, and can look inside the entire knee with that arthroscope. And then we have slender instruments where we can slide the instruments in there and trim out or even repair a meniscus cartilage tear. The scope magnifies onto a video monitor so that we can see a lot of detail that way. It used to be an open surgery, which required a lot of recovery.
Yeah.
Probably at least 3 times the recovery as nowadays whenever we do it arthroscopically.
Is it fair to say now that it's the majority of cases where you can do it arthroscopically, or what proportion do you think?
Yes, that's right. It's probably, maybe 80% of the knee problems can be taken care of arthroscopically for ligament and cartilage injuries and things like that.
And that's probably actually a change since you were a resident, is it not, in terms of the proportion that you can do arthroscopically? It
is, yes. It's evolved, and there are many more techniques for repairs that can be done now than when I did my residency training.
Now, I also know from what we've discussed earlier that you do a fair amount of work in knee replacement, and you've talked about the conformist knee replacement procedure. Can you tell us a little about that?
Yeah, the conformist knee replacement, the conformist company makes a custom knee replacement for that individual based on a CAT scan, where they do measurements and can produce in about a 4 weeks' time a custom-made knee replacement just for that person's anatomy.
That's fascinating.
It really is.
Engineering in the orthopedic surgery world, really.
That's right.
It's kind of amazing. You know, one of the things that's gotten a lot of attention over the last couple of years is the problem or the experience of concussions in sports. In lots of sports. Football, of course, you think of specifically, but in other sports. And I know you've had experience with that. What are your thoughts on that issue and how it's come to the fore?
Yeah, it's one of those problems that was not well recognized for a long time. There was an attitude in the past, say 15 years ago, that when you did get a concussion, or common terms, got your bell rung, that you would shake it off and then go back in. And as time went by, realized that the concussion, or having a blow to the head enough to alter your normal sensations and your normal sensorium and your normal thought process, it's like a bruising of the brain. And then if you get another bruise to the brain or another concussion right after that, you can have serious consequences. So nowadays we recognize that when somebody does have that concussion, they have to be pulled out of action. Appalachian State incorporates the NCAA protocol for the concussion treatment. So the person immediately is taken out of practice or out of contact and then evaluated. And there's a written evaluation in addition to a physical exam. When the athlete comes into the school, as part of their pre-participation physical, they do an evaluation, a neurological evaluation, remembering things, counting down numbers and adding, subtracting, things like that. And so that is on record. And if they get a concussion, they have to do this test again, and you can measure it. It's called the SCAT scale. And you can measure it, compare it to what they had the first time, and they're not allowed to go back to activity until they've completely recovered on this and they don't have any symptoms anymore, such as headache or sensitivity to bright light. Also, since with a concussion it's hard to function academically, sometimes a person is even pulled out of class. A note goes to their professor to let them know what happened. And initial treatment can include things like to decrease the level of the sensory stimulation, such as lights are turned down, no loud music, relaxation and rest for recovery.
Well, you know, it's interesting you mentioned the NCAA protocol.
Yes.
Probably most of us have heard some reference to that while watching a football game on TV, but I've never really heard it described the way you did. So there actually is a before the player starts to play football, this test, and then you have a comparison. So you really have some pretty hard data on how they're performing and can evaluate it that way.
We do, and it makes it more objective, less subjective, which has been a real help when trying to evaluate somebody. And all the athletes that come in, no matter what their sport, go through this same test. So if it's a field hockey player, track and field, even a tennis player, then they have the same pre-participation evaluation.
And is it the case that the concussion issue is also does occur in soccer?
Yes,
so
it does. They head the ball a lot, and so there's concern and ongoing research to see, does that affect a person very much, particularly with soccer starting in the youth and so much participation in the U.S. nowadays when they're very young. And I think the results are still out on, are these going to be a problem or not? Soccer, there's some soccer headgear for heading the ball, but nobody much wants to use those things.
Yeah, you don't see those on the field. Yeah, that's interesting. The you had mentioned earlier, speaking of soccer, the High Country Soccer Association. You have some involvement with that. What is your connection there? Yeah,
that's a youth soccer organization for this area, for the surrounding few counties here, and it's youth participation starting in elementary school level on up all the way through age 18. Where they have soccer games, soccer practice, soccer teams, and they compete in the region. At least once a year, the High Country Soccer Association has a invitation tournament where people come from other areas like Winston-Salem or Wilkesboro, places like that, and have a big competition. Of course, I like sports and sports participation because you learn discipline, you learn how to work with other people. I think they're really good skills to learn for later life when you may have reduced your sports participation. And so this allows those things to start early on, and the High Country Soccer Association here is run on a very professional levels, and so I've been very impressed with the way they do things here.
That's really interesting. So that's kids mostly. What about concussion in kids? What concerns should, when you think about kids playing soccer, playing kids football,
yes.
They don't have an orthopedic surgeon on the sideline. So
right.
how would you advise parents to be, aware of, concerned and careful about the potential of concussions in younger kids?
Yeah, fortunately nowadays there's so many things online. You can access for instance, the NCAA concussion protocol, and you can see what the symptoms are. And it's usually blow to the head, headache. Sometimes a person might get knocked out altogether, in which case that's a time to go to the hospital. That's a time to call EMS and get transported. If it's a blow to the head without loss of consciousness, but headache, not thinking clearly, maybe the balance is a little bit off, that would also be a concussion, and that is when a person needs to be taken out of activity for further evaluation. Particularly, especially with head injuries, I'd recommend to go ahead and get a doctor's evaluation.
Okay.
If the symptoms appear to be pretty bad, go to the emergency room where they're very familiar with how to take care of that. If the symptoms are not quite so bad, you go to the family doctor or even to a sports medicine doctor about that.
Now, when it's not at the level that the youngster was unconscious, or is they're walking in an unsteady way, or they have any of those things that are pretty dramatic,
yes.
What would you advise parents to do when they got clobbered, but they're not quite ready to go to the emergency room or see their physician? Well, what should they observe? What should they look for, like when they go home after the soccer game or the football game?
Yeah, headache is one of the big things, and usually the headache will persist for a few days. If the parent suspects that they've had a concussion, it's best to have them out of activity for at least a week for recovery. And one of the criteria to go back is to make sure a person can run and jump and sprint and that sort of thing like you might do in soccer without having a headache. And that's usually a sign of healing. Also, that make sure they think clearly, they're not sensitive to light or loud noises, and to make sure their balance looks okay. And parents are very sensitive. They would notice it if their things are off a little bit with their kids.
But concussions in kids are a real thing, right? I mean, it's something to be worried about if your youngster is playing soccer or football or other sports.
Oh, absolutely, yes.
Okay, so headache is a big sign. That's a big one to watch for, and especially if it recurs when they go back and do some exercising. If they get a headache, then you worry a little bit more.
Yes, reduce their activity again. If things persist for more than a week, I think that's a good idea then to get checked by your family physician or a neurologist.
Okay, so duration is an important issue as well.
Yes.
Well, I know there is concern about that, and I've heard a lot of parents with young kids who say, "Gee, I don't know what to do about he or she loves it."
Right.
On the other hand, I'm worried, so I think this kind of advice is really helpful to people because it's hard to know what to do.
Yeah, I think so. And as a parent, if your child is giving you resistance about wanting to get back, come to the doctor, and you can blame it on us. We can check them out, and we can keep them out when they need to be.
Yeah, but key is, if there is question, keep them out for a while, at least for a while, and get them evaluated if it continues.
Absolutely, yes.
What about protective equipment? What kind of protective equipment should parents be concerned their kids have?
Yes, in football, it's a well-fitting football helmet. There's been research that if the football helmet is too loose, that you're more susceptible to concussions. And also a mouth guard, because the jaw getting pounded can also cause concussion or problems such as that. So for contact sports like football, where you'd be wearing a helmet, and hockey, things like that, a mouth guard is a really good idea because that cushions the shock also. With a proper helmet fit, there are places online where you can see. You ought to be able to put the helmet on, be able to grab the mask and not be able to pop it right off. But you have to pull the size of the helmet up to get it back off. If you can pull it straight off, it's too loose.
Okay, so fit is really important. That's something parents can check on, actually.
That is, yes.
Yeah, okay, good. Well, it's a fascinating time in athletics, and you know, kids are
Yes.
increasingly involved, and parents are increasingly, you know, helicopter parents watching. So
Right.
it's important that they're informed about exactly what's going on and know what to do to observe. But this is
Yes.
very helpful. I think people appreciate hearing from you, the expert. What things should I look for when my youngster is playing a contact sport?
Right. Great.
Yeah. Well, Bill, thank you very much. We really appreciate your spending time. And the audience out there is, I know, very interested in sports, very interested in sports medicine and kids' participation, and what you've described about how to deal thoughtfully about the potential for a concussion is, I
Yes.
think, very helpful to people.
Well, thank
Well,
you, and
thank
thanks
you.
for having me on to be able to discuss these things.
Our pleasure, our pleasure. Well, that's our program for this week. If you have questions or comments, you can contact us at watchapptv.com, and please join us again for Health Talk here on App TV. I'm Dr. Jay Noreen. Thank you.